Hi guys, same as every day, 30 minutes, one question, one follow-up, and Dr. Yaffe and Dr. Williams will give brief remarks.
Okay, good afternoon, and yesterday we were talking about the number of cases. We thought they were going to go up extensively. They did not go up further from what we had on Thursday, but there was some times of lab ramping up and more of a quality assurance of our new labs that are coming on board all the time. So we're going to talk about our lab testing today, as well as some other measurements of how we're doing as we're completing this first week of the 2-week period, as I said, of one of high intensity and adherence to the social distancing and the physical distancing in that line there, with the ongoing aspects of the essential businesses and shut down a number of aspects there, as all the levels of government, both federal and provincial and different provinces and territories, are taking steps to stay the course in this ongoing struggle and issue to limit, flatten the curve. We'd like to think plank the curve, but let's try to make sure we flatten the curve about COVID-19 at this time as we watch the various scenarios unfolding in different countries around. We'll talk about that in a moment. But first, over to the Ontario data. Let's get those numbers from Dr. Yaffe today.
Okay, thank you very much. So we now have a total of 1,142 laboratory-confirmed cases of COVID-19 in Ontario. Fortunately, we haven't had any new deaths since yesterday. We're still at the total of 18, which includes 2 that were not laboratory confirmed. They were linked in an outbreak in a nursing home. So which means our total number at this point is 1,144 cases. This is an increase of 151 over yesterday. The exposure information in terms of where these cases may have acquired the infection, still missing in about 45% of cases, but in those where we have the information, 29% traveled, 10% were a close contact of a confirmed case, 16% were community acquired, i.e. no travel history, no history of close contact. Of those who had traveled, the United States is the top destination they came from. The United States at this point has reported 108,745,000 cases. And this is already quite higher than China, which had 81,394 cases. The second most common destination was Europe. In terms of the people in the ICU, at this point we're aware of 63 patients with COVID-19 who are in an ICU, and of those 46 are on ventilators. The lab data, which we can speak about more, is showing that the backlog of numbers is going down. We were over 10,000, now we're just around 8,500. And so more work to be done, but it's going the right direction. Thank you.
Right. And so with that, we also have been monitoring not only the backlog in the laboratory testing and how we're making headway as the other satellite laboratories are opening up and then picking up speed after they've gone through their quality checks, and that's excellent news in that line there. The other aspect is that as we're looking at the hospitalizations, trying to keep the numbers and that, we look like there's 63 people at this time in ICU, 46 in ICU, and 17 are not ventilated in those settings there. So we continue to see that number slowly coming up. The actual number in the hospital at any time, we haven't got those exact numbers in there because it tends to fluctuate with people being admitted and discharged, with the more concerning ones, of course, related to intensive care unit admissions and ventilation as necessary in that regard. I think the other aspect as we watch on the Canadian situation here, while we have now 1,144 in Ontario, Quebec, our neighbors to the east, are moved up quickly to 2,021, and British Columbia is holding just around about 790 in that regard, and the other provinces are each dealing with increases gradually in their own respective jurisdictions. So you can see the issue is continuing to move in and around there. We've heard some comments from the federal government around their quarantine order. We are still trying to get clear on how they're going to actually implement that on each of the ports of entry, whether it's at airports, land border crossings, some rail in a few places. Not much as far as Ontario is concerned with water, and looking at, as I said, to tabulate that with the Canadian Border Securities Administration and trying to get the numbers there, and then how are these individuals going to be denoted, how it's going to be documented, and how are we going to participate and work with the federal government in that regard to ensure that the individuals who come in at this late date from traveling, one, are informed of what they're supposed to do, and not only will they be informed, but be educated in what they need to do, be assisted in doing that, and we want to be able to help them in that regards, because I think for the most part they want to do what's right, understand what they're supposed to do, and then to get advice on how and what they can or can't do so they can honor the order properly for their period of 14 days. Assuming the fact they're all coming across asymptomatic in that, and then how they would be tested if they needed to be, if they develop symptoms, and so that it's coming back in the country, they would need to be informed what's currently going on, how does it work, how does the self-assessment tool work, how does telehealth work, how does your primary care doctor system work, and because they've been out for a bit and may not be up to all the things, as you're aware, have been changing day by day. And you've heard today the Premier and our Minister speaking on various issues around supply chain, gouging, and monitoring the ordering and supplies and materials. This is a very critical thing as we try to ramp up all the issues around personal protective equipment and our supplies and orders. Many things coming in from different areas, orders from the federal government promising, and we're trying to keep on top of that and making sure that everyone gets some, but the priority ones get first, but we don't want anyone left out, so we have to keep monitoring that through our regional offices of Ontario Health to ensure that when we need it and when we ramp up with any further cases than that, those various sectors will be ready to do that. And that's why we keep seeing that with the limitation of elective procedures, still trying to address those that are not totally elective, that still need to be dealt with in a timely fashion to understand those individual cases and make sure they're taken to the right tables with their healthcare provider as well as with the facility to understand what their perspective is and that they would get the care they need. If it's not elective, then it's on an urgent or semi-urgent basis, because during this time of preparation, we want to make sure that no harm is done and that people who need the care urgently get the care they need in an urgent basis in a timely way. So we're still trying to monitor all those aspects in that regard. And with that, our emergency department visits with the assessment centers, a large number of them up and running, because we have almost 77 sites up and running, so our emergency visits have been dropping. So that gives them the buffer, if you may, if all of a sudden have to deal with a sudden increase, if it did occur, as well as the hospital admissions, and the occupancy rate is down to quite a bit of a low in 10 years. So they're building up that resiliency to be able to respond in that. We're continuing to work with our long-term care ministry and as well as with our seniors ministry around the long-term care facilities and the retirement homes and other venues that we're looking at on a fairly rapid basis of what we might be able to open up quickly to increase our capacity, looking at all different scenarios and how we might have to proceed. So all things are moving in a direction. We continually have more briefings again with our decision makers, both of the Premier and our Minister, Deputy Premier, as well as with the Cabinet, and update on that so that they are fully appraised and responding as they see fit, following on their emergency order and actions therein. So those are the general summary of where we're at today. This is the end of the first week of the 2-week of intense monitoring. This coming week, which will be the second week of the initial school closures post-March break, is one to be monitored. We're The numbers of tests and positives, I'm a little surprised they're staying in the mid 100s and upper 100s. I thought we might be over 200 shortly, but we're moving on the backlog of tests. So a few tests are only a thing to monitor. We need to see how the trend goes over the next 4 or 5 days. So my general message is, again, you're doing well. Keep at it. Keep doing all those inventive ways of staying connected while being separated. And it's like communal gathering and isolation all at the same time. It seems like an oxymoron, but people seem to be doing it really well. And I applaud the Ontarians for doing that, the retail industry for stepping up and helping in a way that still delivers the essential services while protecting their employees and the shoppers, that they get what they need when they need to get it in a safe and a timely way while trying to stay home, and to honor that aspect as well. So with that, I'm going to open up for questions, and thank you for your time.
Okay, we'll take the first question.
Your first question comes from Carrie Virama with CBC National News. Please go ahead.
Hi there. I asked the Minister of Health about this. South Lake and Newmarket is reporting 6 of 15 ICU beds are in use.
Could you move closer to your microphone? You faded there.
Kari, we can't hear you. We can't hear you. Can you come closer to your phone, please? And maybe take it off speaker if it's on?
Not on speaker. I'm just hearing a bit of an echo.
That's better.
So South Lake and Newmarket is reporting 6 of 15 ICU beds are in use with COVID patients and are warning that their ICU will fill up in the coming days with COVID patients. Are there any other hospitals in the province providing similar warnings? The Minister of Health alluded to the possibility of shuffling caseloads to other hospitals. Is that happening anywhere in the province?
Oh, thank you. And to my knowledge, that we haven't heard others talk about that current load. They're talking about concerns about imminent, and that could increase soon, and that's all part of the active reporting. If there are cases, they don't all present equally throughout, and so part of that is to ascertain if one hospital is being overburdened. Can we reassign them to other facilities around and handle that? And that's part of the regional model. That's part of the regional issue of shifting and moving, first of all, within the facilities within a region with our regional Ontario health planning, and then those coordinate up to our command table about moving on a larger basis and how we might be reassigning when they're being transferred by, say, paramedics to a different location at that time, and how we would do that to maintain at least some buffer capacity at each hospital, knowing that this is going to be our challenge. If we get an increase, it won't all occur equally across the province. It's going to happen in different areas and different times, and it'll wax and wane in some extent in that. So we're going to have to be nimble and to keep the data up and keep responding.
Follow up? Follow up? Follow up?
Hi there. Sorry about that. How many COVID tests are we currently processing daily? You talked about working to clear the backlog. The government suggested the target will hit 5,000 tests a day by week's end. Are we going to hit that target? And what is the estimate on being able to clear the backlog?
So I'll let you try. I did my own back of the envelope calculation, but I'll let you comment on the general issue, Dr. Yaffe.
Okay, sure. I know we're doing over 3,000 a day at this point, and aiming for 5,000 by early this coming week, and aiming for something or close to 19,000 by mid-April.
Okay, next question.
Your next question comes from Travis Daharaj with Global News. Please go ahead.
Hi there, doctors. I'm just wondering, we saw that a man in his 70s who had returned from a trip to Portugal passed away last night in the ICU of London Health Sciences Centre. I'm wondering if that death is included in your updated numbers, and also what the recovery rate of people in Ontario that go into ICU for treatment is for COVID-19.
Well, we are not aware of that. The death in London Health Sciences. It hasn't. If it was from COVID-19, it hasn't been reported at this point. Perhaps they haven't figured out the cause of death yet. So that as soon as we know, we would add it to our data.
Follow up?
And I was just following your second part of your question there. It's a good question. We know of some who have recovered from intensive care and venting. Our number there is still small, but that would be a good one to collect or to understand as we go forward to see what is our recovery rate in that aspect. And so I haven't been advised of any statistics. And again, as Dr. Yaffe said, the London case, if it came in late, it wouldn't be part of our report today. It'll be added to the report tomorrow. And they may be in the process of having sent samples in for testing. And we have to wait to see. It hasn't entered into our positive lab test, but it may be a suspected case in that and just needs laboratory confirmation.
Okay, next question.
I have follow-up.
Sorry, Travis, follow up.
So, doctors, I'm just wondering about the supply of 55 million masks that were stockpiled after SARS. I know that those masks have expired. Have they all been destroyed? And if not, how many masks from that stockpile are available to be distributed to hospitals in the province?
Well, you have to remember that when those were stockpiled after SARS in 2003, by 2013, most of them were already 10 years old. So a lot of them were actually taken out of that amount way back nearly 5-6 years ago. There are some left over because they weren't all purchased at the same time, and there has been some replenishing of certain supplies and stocks and that. So some have expired quite a while ago, and some have just expired. As a result, we're trying to get direction from the manufacturer for manufacturers and also from Health Canada about the usage of expired N95s, if they have some level of inspection, what they can or might or could be used for. We certainly have clear direction that they could be used for fit testing because sometimes it's the elastic band that's the weakness, sometimes it's the actual vent. And then the other aspect they might use them for is that they could still suffice quite well in place of a surgical mask, but then we'd have to make sure they were at least visibly denoted on the mask that it was not a N95 anymore. It was a surgical mask equivalent. So we're looking at all those ideas there as we continue to ramp up our supplies and orders with all the other ones coming in. And we've been encouraged with the various sources that are coming and promises and that. So it's a full-time court press in that matter by our team working on personal protective equipment.
Next question.
Your next question comes from Salman Rakuki from Canadian Press. Please go ahead.
Hi there. The province has announced that they want to reduce gatherings to just 5 people eventually. And I wanted to ask if this would have any sort of effects on how businesses like grocery stores would operate and whether you'd recommend any sort of changes.
Yeah, we're in active discussion of what we might want to do. One thing we're trying to differentiate is the big concern of a lot of the other provinces is the public gatherings of more out in public places, in parks and on the streets, etc. and that. Meanwhile, there are what you call essential services such as retail, food, groceries, where to have more than, say, number 5 in a store at any time would not be surprising when you have employees and shoppers. But having 100 people in would not be acceptable. So some of them are already doing in retail and essential services, taking steps to maintain the physical and social separation, which is the key in there, and also to have the proper things to protect their cashiers and vendors in that light. So that's so you have to differentiate between numbers in public gatherings versus events, or events that are actually tabled, or you're talking about internal things as in essential services and businesses. How would they continue to operate in a way that people can acquire those essential services and yet not compromise on their aspects of physical and social separation? So all these things are in open and dialogue at this time. And if there are any changes, we would hope to have that out to you in a short time.
Could you also maybe talk about what kind of effect you hope that the plan by the federal government to stop people from traveling domestically if they have symptoms, how that would affect just overall rates in Ontario, and whether there might be any plans in Ontario to also include that ban on bus travel, because the ban currently only includes trains and flights.
Because the federal government did announce concerns with travel domestic within Canada if you're symptomatic. Of course, our thing, if they were leaving, disembarking, or going on a flight or something here across into other provinces, if you're symptomatic, you shouldn't be at the airport anyways. You should be home. And so you should not be flying. You should not be traveling the train. You should not be going the bus. You should not be out in the public. You should be staying home. And we can't emphasize that strong enough. And you may feel that there's pressures and issues, but by doing that and by succumbing to that kind of pressure, you can put a lot of people at exposure, at risk, and cause quite a bit of consequences. So we ask you to take that seriously. As far as how that might affect all the different types of travel and how I might monitor that, that's all being worked out, because you just heard some announcements today by the Prime Minister, and so it's just fresh out. At the same time, how does that impact us? So far on our cases and issues and concerns, we haven't had a lot that would say traveled from province X or province Y. We've had a few. And as Chief Medical Officer of Health, if we know of cases that have come over from our province or theirs, they want to share the information, or the other way around, because we would want to do case contact back here that they might have been symptomatic already in one province and they need to know that information. So we share it as much as we can between each other. It hasn't been a huge number, fortunately, but we have to monitor that as we're getting more and more so-called case communities arising unrelated to contacts and international travel.
Next question.
Your next question comes from Kelly Grant with the Globe and Mail. Please go ahead.
Hi, thanks for taking my question. I wanted to ask about the cases in nursing homes. Are you intending to still stick with the policy of stopping testing after...
Kelly, we're having trouble hearing you. We're just having a little trouble hearing you.
Okay, I'm going to be louder now. Am I louder now? Can you hear me okay?
Yes, we can. Thank you.
Okay, I'm as close to the phone as I can be here. I wanted to ask about the nursing home cases, and I'm wondering if you're planning to stick with this sort of flu outbreak-based policy of stopping testing after 3 cases. I understand the reasons why on the ground, but I imagine in terms of tracking the cases, we're going to see a lot of deaths in nursing homes. Wouldn't it be beneficial to know for certain that they had tested positive?
Yes, we looked at that. We're trying to assess, because when we have an outbreak in a nursing home or a long-term care facility, that's based on when you have a cluster of syndromes, a syndromic of respiratory. You don't say, well, we have to wait for the test results to come back. So then we would declare, if you have one or two or more in a certain area, you would declare an outbreak and start your investigation, which includes a lot of steps and processes that are laid out in our protocols. Part of that, if you identify the organism, and in normal flu season, since flu is quite endemic in the province, after a while you know which areas of the province has lots of it circulating. There is not much need to go any further than that, because you'd already undertaken your steps previously to vaccinate all those residents for flu, and you start using Tamiflu to treat them proactively, so you try and curtail any outbreak. With COVID-19, we don't have a vaccine. And with COVID-19, our antivirals, such as Tamiflu or also Tamivir, do not work in the case of coronavirus. So we don't have that venue there. Therefore, how should we alter our programs and services? So we've looked at that to say, well, and talk to our consultants on how we could assess and pick up quickly on any type of outbreak in there. Again, if it was syndromic respiratory, but sometimes we're finding with the COVID-19, some of our elderly people in these residences don't give very much evidence of the symptoms. Some do not mount much of a fever. They don't have a very significant change in their cough. Some may be coughing all the time anyways. And some have always a certain level of shortness of breath because of their comorbidity. So it is a challenge for our long-term care staff to notice that there's been a change, if you may, in the person's status, and that they would alert them to the fact that something's going on. And so we continue to delve into that. And as far as our testing, we may choose to test more at this time in the case of an outbreak, simply because people are asking those questions. So we're looking at how we're altering our protocol to make it more addressing the uniqueness of the COVID-19 as we're learning, presenting itself in this high-risk, vulnerable population. But our priority mostly is keep it out of the long-term care facility. That means putting a real, I guess someone might use the term, wall around them. And that means careful screening of all visitors, limiting visitors, only essential ones, and of your staff, and making sure you're not moving infections from one facility to another by staff movement, etc. So these are all steps that we're assertively directing and dealing with in discussions with the Ministry of Long-Term Care.
Follow up?
Yeah, what reason would there be to not just test everybody in the nursing home? Like you say you're thinking about it, why not just go ahead with it?
2 or 3 reasons. One is that if you went and tested everyone in all the nursing homes all the time, we wouldn't make much progress on our other testing of cases that are symptomatic, so it would use up all our laboratory testing capacity. Plus, that means then some of the priority ones would not get seen. Right now, we decide that cases in a long-term care facility that we suspect there's an outbreak is a priority testing of those individuals. To test everybody all the time, each time, a negative result doesn't tell you much except that you didn't find it that time. The chance of just finding a positive now and again on regular testing is a little bit like a fishing expedition. So you got to do something a bit more timely and effective and efficient than doing testing all the time. So we're looking at ways we might do that to monitor that better. And if we have to do an outbreak investigation, how we might do wider testing without compromising our overall provincial laboratory system, which still is mostly driven by a lot of people from the public sector, traveling sector, returning symptomatic, and of course meeting the needs of testing our inpatients, the ones in intensive care and emergency departments if and when they do arrive, our healthcare workers to assess them as well, and then are always concerned about some of our more isolated remote communities, as in our First Nation citizens, to make sure we have those tests done in a timely fashion. So it's all a matter of a right balance and to get it the best result for the best procedure, trying to gain the best protection. And if it doesn't move the yardsticks much on protection, then we should look at other things we're trying to do, and that's what we're really trying to drive at this time.
Next question.
Your next question comes from David Haynes with Queen's Park Briefing. Please go ahead.
Hi there. Last week you said that you would reach 5,000 tests per day by the end of the week, and I believe Dr. Yaffe just said that will be reached sometime early next week now instead. Why has it taken you longer to reach that mark?
When Dr. Yaffe gave the number there, I was doing my back of envelope with the ones we sent out to some other labs out that they haven't processed them all yet. My total that I got out of that one was that today moved out was around about 4,100, so we're getting close to that number. And so that's a matter of how their data is going to come into our system from those other labs, and that we're still working out the logistics of that, if you may. So I see in potential there we could have done probably about 4,200 today. So we're pretty close to the mark, and so I'm still optimistic. Maybe by the end of the weekend, early part of next week, we'll be at that 5. But it's all these different labs and components and groups coming together that takes coordination and timing to get it to all come with the results so we have them in front of us to speak at the table here.
Yeah, if I could just add to that, I think as we add these new labs, they have to go through testing to ensure that their tests are valid. So the first 500 or so tests that each lab does have to be verified by the Ontario Public Health Lab. So that's a very, quick step, but it has to be done before those numbers can start to go up as well.
Follow up?
You previously commented on modeling for various scenarios and so on. In British Columbia yesterday, they did a walkthrough showing what kind of modeling they currently have and what that means. Have you done your own modeling for different scenarios that might happen, and would you be willing to share those numbers?
We have been doing quite a bit of looking at modeling over a while now, not just one model, a number of models. We have used our Public Health Ontario to develop some models and assess some of the other ones, the Imperial model, looking at what's similar to the BC model, what the UK is doing. We also have a group of academics with the Atlanta School of Public Health combined with the University of Toronto and other experts to look at their modeling and what are they putting forward, because there's different ways to do it and different ways to carry out the analysis. And our sense is that instead of just having one model, can we look at a number and then ask our experts to say, so which one's closest to our Ontario scenario? And we're doing those discussions live time right now. A number of things are carrying out. So I can't give you that analysis today, but hopefully we'll be coming out with something very shortly on that, because we want to make sure we're looking uniquely at how does Ontario figure and where do we place ourselves in the various modeling projections, such that we can plan with various scenarios around hospital resources, ventilation equipment, PPE, etc. So this is all in a very much dynamic conversation at this time.
Next question.
Your next question comes from Rob Ferguson with the Toronto Star. Please go ahead.
Hi there, doctors. Today, the federal government said 30% of the people in hospital with COVID-19 across Canada are under the age of 40. So I wondered if that jives with the percentage here in Ontario, and if you have a breakdown of the age range of people in ICU now.
So Rob, you said 30%?
Yes.
Okay. That was pretty close to what they put out last week. It's interesting, most of the ones are in the ages between 40 and 69, but by demographics, we have about 30% that are over 70 and 80 in the hospital at this time. The number seems to be changing and shifting fairly quickly there. So it's a ballpark that I would say, if you say the age group 40 to 60, 40 to 50, that would be about 30%. 20 to 30, it's a small number. So we want a bit more breakdown the way they're clumping them together. That might be misleading that say, okay, the majority are 20 to 25. That's not true. So I think they're doing the 20 to 40 group. So we're trying to, as our numbers are, we're getting enough numbers across Canada, they're getting large enough that we can do some better analysis. So we're getting these updates and segmenting of the different categories. As the numbers get larger, we can break that down even better. So I think your 30% was correct at this stage, but how that breaks down into the younger part of that age group and the older one, I haven't seen those numbers yet.
Follow up?
Do you have a current number on the number of healthcare workers that are infected now, and a cumulative number on that?
I'm trying to look at my data here. No, we have. If Dr. Yaffe has that number. I'm looking at my large sheet here, and let me have a look here. I'll try and get that back to you, Rob.
Okay, moving on. Next question.
Your next question comes from Kate Allen with the Toronto Star. Please go ahead.
Oh, I'll just step in here. Rob, I found my number. Right now, the total across the board of healthcare workers, we don't know if they're from in the hospital or from travel or from case contact. The number I have here is about 91 since the start of the whole episode in the end of January. But again, that's a cumulative total, and it doesn't break it down if how many of those were arrived at on the job at the healthcare setting.
Okay, moving on. Kate Allen, first question.
Hi, my question functions sort of as a follow-up to Rob. Is when you get maybe slightly larger numbers on hospitalizations, ICU admissions, and people on ventilators, would you publish those or release those numbers in age-stratified categories?
Just trying to say, in the 8 stratified categories?
Sorry, age-stratified.
Yeah, the age ones originally had the ones I've been receiving from the national data, where in the 60 and above, and then there was the 40 to 60, and then 40 to 60, and there was 20 to 40. They had some in the numbers under 20, but that was a really small number.
Follow up?
Sorry, what I'm asking is, will Ontario release stratified hospitalization numbers? when those numbers get big enough that it doesn't look misleading, because just happens to be a large clump under the age of 40 or whatever.
Right. Thank you. I misunderstood your question. Yes, it would be my anticipation. I'm not hoping for large numbers, of course, but when you have a larger N and we can stratify it, so it makes sense, we would be doing that.
Hey, Kate, you can have another follow-up because the misunderstanding.
I was touched the total number of hospitalizations. Can you repeat that part?
Yeah, we don't have that data at this moment, but we could get back to you.
Okay, next question.
Your next question comes from Mo Fahim with Vista Radio. Please go ahead.
Hi. First of all, thank you for doing this, and thank you, Dr. Williams and Dr. Yaffe, for taking my question. First question, any update on the vaccine research front?
I hear lots of reports about some preliminary concepts that people are putting forward using various techniques to produce it and different methods to use to carry out the research. But right now, from our federal people who are getting back to us, there's nothing imminent at this time. And remember, in vaccine world, imminent means like 4 to 6 months off. So we're waiting to hear some. We hear some promises of something that could be very quick. But then, of course, they haven't undertaken any clinical trials. And safety always has to be a key factor as you're dealing with any new products coming out.
Follow-up?
Thank you. And can you possibly comment on rumors of hydroxychloroquine being held by the U.S. president as a treatment to COVID-19?
So, yes, certainly we've heard about that, and I believe there are studies ongoing currently, but at this point there's no evidence that it works for COVID-19. It is an effective medication for some other things like malaria in certain cases, and so it's not recommended at this point. We're waiting for the results of the studies.
Next question.
Your next question comes from Sarah Ferguson with Sudbury.com. Please go ahead.
Hi there. Thank you for your time. My question is, Ontario announced the proclamation of the Supply Chain Management Act Saturday in its effort to purchase and deploy critical equipment. My question is, what benefit will this act be to residents as opposed to participation in federal collective purchasing?
I think the aspect there is, one, how will it help Ontario citizens? Certainly the aspect of federal procurement, our own procurement, whatever way we can do the procurement is going to be critical to ensure that our healthcare workers, our healthcare facilities, and all those involved in those essential services, whether it's dealing with the homeless and different groups like that, is there at their provision. I think the aspect that we're trying to deal with here is that in order for the government, the cabinet, the premier, and our minister of health, and of course our command table to understand what we have, we do have to have a clear declaration of what everybody has in store and in stock at this time, so that we can ensure that there's a fair and reasonable distribution of what's out there. Knowing that some may have stockpiled a certain amount and may be reluctant to tell us what's there, but at the same time, if that was present and while we're waiting for supplies to come in and there was another facility that was running out, why would we not move that material from that place over to deal with that? Because in another few days the supply would come in, and we compromised one facility because one was unwilling to either declare or make it known what was there. So in the essence, we're in this together. And there's just one major stockpile, that's all of us, and we need to move it to where it needs to go to ensure the ongoing care and the safety of all our healthcare workers as they undertake to take care of these citizens when they become ill with COVID-19.
Follow-up?
To clarify, will the province of Ontario, or I should say, does the province of Ontario intend to still participate in federal collective purchasing?
Oh, that's what I said at the outset, we are. And we have our orders in. We're calling, phoning, emailing. We're doing that as assertively as we can. So yes, that's all ways of trying to procure. We're going there.
Next question.
Your final question comes from Mike Walker, CTV News. Please go ahead.
Hello, and thank you for taking my question. It seems like almost daily now this week we've been hearing about more employees at essential services testing positive for the virus, like grocery store clerks, for example. Are you considering, with, I guess, the risk to both employees and customers, are you at all considering any more measures to protect people who visit these essential services?
I would say we heard of a case. We haven't heard of a lot. We hear some with the number of people that are out there moving around. So it's something we're watching, or we continue to get questions from various essential services and their employers about how they might improve their services better. We're continuing to observe that and monitor that. And we're asking, say, some essential companies that are doing their businesses, there may be some components of their business that are not that essential, and they could curtail those while still offering the essential components. They could do things to decrease the size of the workplace area, that people are not in close contact. They could do things more virtually, order online. So there's various ways that we're continually nudge that, because some of the people, some of the cases you're referring to, we're talking that they might have got infected before we came to the essential services, almost like 8 to 10 days, 12, 14 on the cases this we're talking about. So it's a matter of ramping up all these protection things and to ensure the safety of the employer and the employer's staff, as well as the customers who are coming to get those essential services. And they don't have to come physically. More and more are being done by virtual, by delivery, and by extension. So we're getting better at it all the time, but it doesn't mean we can't keep working at it more.
Follow up, and this is the last question.
Okay, the numbers announced today much lower than what you had anticipated. Do you still expect to see, I guess, during this critical time, the number of cases to jump 200, possibly more?
That was my anticipation when we had it. I assumed that we'd be up in the mid-twos, especially we're doing with the backlog of the tests. We still have a backlog of 8,400 or so to deal with. So I was surprised we haven't jumped up that fast, and we'll have to keep monitoring the situation. These are trends and directions. 1 day or 2 days doesn't tell us everything. So let's wait to see what the next few days bring, and we'll get back to you on a daily basis.
Okay, thanks everyone.